So again, my name is Janice Guzman. I'm a nurse practitioner, nurse scientist based in Tucson, VA, and also part of the steering committee here. Welcome. This is our last session, and it's going to be exciting because we're going to see a fight. So, but this is our debate session, and we have the pro group and we have the con group for the question. TTR levels are a valid surrogate for assessing treatment response to stabilizer therapy in ATTR cardiomyopathy, yes or no, okay? So the way this will work is the pros group will come first. They have 9 minutes, okay, to make their case. And then the con group will have 3 minutes to ask questions, clarifying questions and things like that. And then the con group is gonna come, you have the same amount of time, and then the pro group will ask questions. And then once the questions are asked, I'm going to have the pros come back, make a rebuttal, make a case again, finalize their statements, and then it'll be your case, your turn. And in the end, I'm going to ask you guys, what do you guys think? Any questions? Oh yeah, we'll do that too. So before they get started, we do want you to please answer the question by, yep, thank you. I think some of you guys did it already. Yeah, yeah, great. Are we going to show the results or not yet? Okay, after everything. Okay, so I'm going to give you guys, let's see if I can do it too, like 1 minute. Are those responses? The beeping? Oh, sorry. So if you guys did the question already, basically it's asking you, yes or no, TTR levels are a valid surrogate for assessing treatment response to stabilizer therapy in ATTR cardiomyopathy. So we want to know if either group at the end convinces you otherwise, okay? So while we're doing that, should we do this first? Oh, there. So our pros from the end. Okay, thank you. Ooh, pros, you have your work cut out for you. Oh, yeah, see, that's good. But we don't know how many of your folks are in here though. Just kidding. All right, so quick bio. So Dr. Zachary Wilson, my far right, is from Banner Health. He is a cardiologist and graduated from the University of Arizona College of Medicine, Phoenix. In 2019, he works in Phoenix, Arizona, and specializes in cardiovascular disease and internal medicine. His research interests includes cardiac MRI evaluation of cardiomyopathy, blood volume analysis, ASCVD biomarkers, and cardiopulmonary exercise testing. Next to him is Dr., and I'm sorry if I'm gonna not say it right, Shirin Doroudgar is a PhD at the U of A. She works as an assistant professor in the University of Arizona College of Medicine, Phoenix Department of Internal Medicine, and is an active member of the Translational Cardiovascular Research Center, where she leads a research group in cardiac molecular biology focused on understanding changes in protein homeostasis and cellular stress responses that contribute to heart disease. Thank you. So that's our pro group. Our con group, my far left, is Dr. Christopher Glembotski, who is a PhD prepared from the University of Arizona. He is a renowned researcher in cardiovascular disease with a remarkable background and a wide range of accomplishments, not only as a scientist, but as an educator and leader. He is the inaugural director of the Translational Cardiovascular Research Center, the vice dean for research, and a professor in the Department of Internal Medicine. Dr. Glembotski has been recognized as an educator and researcher with several accolades that include receiving the American Heart Association Established Investigator Award, the Albert W. Johnson Research Lectureship Award, and being named Distinguished Professor of Biology in 2019, SDSU's highest research honor. And everybody knows Dr. Sandesh Dev, cardiologist from Southern Arizona VA healthcare system, as well as ASU. And with that, we're gonna give you guys 9 minutes. It starts as soon as I sit down.
So that we can get up. Okay. TTR levels are a valid surrogate for assessing treatment response to stabilizer therapy in RP. Ready off to a good start. So our team is serum TTR levels should be used as a marker of treatment response to TTR stabilizer therapy. Our core thesis is that serum TTR concentration is a biologically meaningful, pharmacodynamically relevant, and clinically informative biomarker that reflects effective TTR stabilization and correlates with outcomes in ATTR cardiomyopathy. Our first claim is that TTR levels directly reflect the mechanism of action of stabilizer therapy. And we argue that TTR stabilizers work by preventing tetramer dissociation, not by reducing TTR synthesis, and stabilization increases circulating TTR half-life, and this leads to higher steady-state serum TTR levels. Therefore, a rise in TTR is direct evidence of target engagement. Supporting evidence comes from a lot of different places. TTR stabilizers bind the T4 binding site of TTR. This, as we said, increases tetramer stability. Biological impact of TTR stabilizers reflects endogenous TTR turnover on the order of days, not the rapid pharmacokinetic effects alone. In vitro assays of tetramer stabilization and kinetic stability show concordance with in vivo increases in circulating TTR observed with effective TTR stabilizers, and across clinical trials and observational studies, TTR stabilizer therapy is consistently associated with increases in circulating TTR, supporting target engagement, though changes do not directly. You want to take this?
Yes. So our second claim, move them out. So here. Our second claim is that TTR stabilizing therapy consistently raises TTR levels across both wild type and variant. This biomarker must behave predictably and reproducibly for it to be a clinically useful marker. This has been shown in both wild type and variant types to increase with stabilizer therapy. This data comes from Falk's group, 2021. It was published in JACC Cardio Onc. They looked at a retrospective cohort of unrandomized patients that were on tafamidis therapy, found a mean increase in TTR across all comers of 30 to 35%. In the wild type variants, they had a smaller increase of about 30%, and in the variant type of 60 to 70%. They would also point out in this group, there was a consistent finding in patients also in diflucanol. Those were explicitly excluded in this paper. However, this was also found to be present in former published literature. Now, clinically, TTR can not rise in a few scenarios, and I feel like this is a very clinically important point. Non-adherence would be one reason for a patient not to have a rise in TTR, and with a drug as expensive as tafamidis and acoramidis could be, it would be very important to understand if the patient is, one, either not taking it for non-compliance reasons, or two, maybe is not understanding appropriate dosing or needs some counseling on that. So that would be one potential reason to take it. Also, a caveat with TTR therapies is that it is an acute phase reactant, and so it will go up and down with inflammatory states. Typically, in our clinical practice, we'll couple it with CRP to try to get a sense of their underlying inflammatory state and to couple it to that. And then obviously severe malnutrition, it's actually one of its most commonly used prealbumin or TTR in the clinical practice. So patients that are malnourished for whatever reason may not have a appropriate rise. So higher TTR levels are associated with improved clinical outcomes. There's published data on this. Biomarkers that reflect disease modification should correlate with outcomes. Makes sense. All of our clinically useful biomarkers do. So the baseline TTR and on-treatment TTR changes were associated with prognosis. This was shown in a separate study that was published in 2025. This was by Myers Group and JACC, and they showed that patients with low baseline TTR actually predicts all-cause mortality. The cutoff threshold for this was 20, and generally a clinically normal range for prealbumin would be somewhere between 20 and 40. So patients less than 20 would be considered to have low, and those predicted that they had actually increased all-cause mortality on Kaplan-Meier data. The phase 3 data, and this wasn't published in the initial trials, it was a separate publication, showed that this reduced all-cause mortality actually correlated with the 5 milligram per deciliter increase in prealbumin levels. The higher they went, there was a 30% relative risk reduction for every 5 increase in your levels of prealbumin. There was also a reduce in cardiovascular hospitalizations, and as mentioned, is proportional. This is another key point. If you are going to be using it for monitoring, silencers reduce levels of TTR because they prevent synthesis. So if you have a patient on silencer therapy, there's at least not much published data on using this for tracking. And if they're on combination therapy, that would be another thing to consider. Very hard to predict what that joint action would be. Importantly, in this trial, they measured a baseline for the patient's own reference, and then they looked at it at 28 days. So that's something to think about as well. And then every 3 months trending there afterwards. There are no standardized protocols for this. It's never been prospectively studied. Claim 4, TTR would be considered a practical, low cost, and early marker of our treatment effect. These therapies, as I mentioned, are quite expensive, but yet provide good quality of life benefits and reduction in mortality and morbidity in these patients. But the benefits accrue very slowly. As anyone following a patient, you having signals, early signals, can help you to have important prognostic conversations with your patients. I wouldn't say that it can guide therapy at this point. However, still very useful in that respect. I will say you can get a prealbumin or TTR level pretty much any lab or any hospital anywhere. It's widely available. It's inexpensive. It's something that would be used routinely to assess sometimes nutrition. So it's not something many clinicians would be unfamiliar with. It can, like as mentioned, used for adherence, a non-responder. That is, somewhat to be studied. And then could support continuation of therapy. That's another thing. These are some other important points to consider. Early disease, you may not see the improvement in NYHA stage. You may not see the improvement in 6-minute walk because the patient is so early that they haven't developed significant diastolic dysfunction and or disease from the amyloid. So maybe a more useful marker, this is more of a hypothesis that could be tested. And then those with borderline clinical progression. And I would say that we'd never use this in isolation. And so this is important with Claim 5. We want to know that it complements clinical assessment, doesn't replace clinical assessment. It should be used along very standardized markers that are clinically used. NT-proBNP or imaging markers on echo and cardiac MRI, and then functional status, which is usually assessed by a 6-minute walk, a cardiopulmonary exercise test, and patient symptomatic reporting. Also to mention up there is troponin, and then the frequently used staging systems of the National Amyloid Center and the Mayo Clinic staging. So I think that is our closing. TTR is the most direct and biologically relevant readout of stabilization efficacy we currently have. Ignoring it is basically like treating a disease state without having any monitoring, treating hyperlipidemia without looking at your LDL levels. So for right now, this is what we have, and I think it could be a useful marker. Thank you.
Great. You had 30 seconds left. And now we have we just get this.
Oh.
We can take questions.
Yeah,
from the
you
other
have,
two.
actually, just from the cons group, you now have 3 minutes.
Clarification needed.
Is that for questions?
Just
Just for you
clarification.
guys to them. Yes.
Well, I have a question without a question mark at the end. And they're so good at presenting all the evidence that they kind of tip the balance away from the pro and to the con direction. So it's like pro and con, and now we're saying somewhere in between because it can't be used alone, right? And we know that the current turbidimetric biomarker assays that any physician in any clinic in any state of the country can use, they may measure the total TTR levels or the levels of TTR that actually is not disease causing. So that was your claim 1, I think, which I would debate because of the dynamics of TTR in the circulation and what is actually measured in the clinical lab using the standard clinical assay.
Are you aware of any data that refutes your hypothesis, that doesn't agree with your hypothesis?
Any published studies that go against the findings?
Correct.
Off the top of my head, no.
Okay.
Show you that later.
But we'll see what you guys have to show us.
And you said that we should be measuring it, but then you said we shouldn't be changing therapy. So could you help me understand that
Perfect.
dichotomy?
Yeah. Frequently, we'll measure biomarkers to get prognostic information. So whether or not you need to have a goals of care conversation with the patient, maybe you need early advanced therapies, maybe you need to move them towards palliation, that sort of thing. These help with decision makings. Obviously, one lab wouldn't help you do that in isolation, but it can be useful for that conversation.
Is it possible a patient that's not on a stabilizer could have an increase in their TTR level?
Absolutely. With good nutrition, lab variances.
So how would you know the difference, whether it's due to the stabilizer or due to a change in something else?
We can follow them longitudinally, and then we can account for those co-founders. So there's been, evidence that we can independently be able to see TTR is associated with various kinds of benefits. And going back to your question, Dr. Glembotski, most of us don't measure TTR in any patients. So right now, I don't think anybody's TTR levels are measured, only in clinical trials. So
Seconds, any other questions?
The debate is about whether TTR is a biomarker, not whether you should use it along with other tools like BNP and ECHO and so forth.
All right, thank you. So now the cons group have 9 minutes to make their.
Okay, thanks to ChatGPT, TTR levels are not a valid surrogate for assessing treatment response to stabilizer therapy in ATTR cardiomyopathy. Okay, so why are we even thinking about this? First of all, we do need to identify an assay to promote early detection, just like we do for troponin. We do need a method of risk stratification, just like LDL cholesterol. In particular, for this discussion, we do need a mechanism of monitoring disease progression, such as NT-BNP. We do need to guide treatment decisions. And again, relevant to this discussion, we need to evaluate treatment response, just like hemoglobin A1C. And also we need to improve clinical drug development and clinical trials. So when we say treatment response, what are we talking about? There's two perspectives to look at. One is biochemical response, and there's conflicting evidence that TTR levels are actually correlated with clinical response. For example, a hereditary polyneuropathy study did not find any correlation. Furthermore, this assay is not well developed. What do we mean when we say TTR levels? Third point, TTR dynamics are not well understood enough, so we can't really say we have an assay. And next, validation of a standard assay needs to be done in clinical trials. Now, the other perspective of treatment response, the clinical perspective. And as the other team has acknowledged, clinicians must integrate the entire spectrum of outcomes, clinical, functional, and biomarker. So the TTR levels could be increasing, but the patient could be doing poorly. This is amyloid cascade. Now, there are numerous variables that can affect TTR levels: age, sex, race, nutritional status, infection, or generalized inflammatory states. And the current consensus, clinical expert consensus, is that we should use various parameters, clinical parameters, quality of life, and two biomarkers, NT-BNP and eGFR. So prealbumin or transthyretin is nowhere to be found. This is a study that I would like the opposing team to explain. So in hereditary polyneuropathy, the founder of tafamidis studied patients who had verified hereditary polyneuropathy, and they actually measured not only sort of aggregate TTR, native and non-native. They specifically measured each of them, and they found that native TTR, which is the normally folded protein, increased by 56%. And they found that non-native protein decreased. However, there was no correlation with clinical response. So in other words, you could not distinguish responders and non-responders by their native TTR levels. And so their conclusion was that native and non-native TTR concentration changes cannot be used as a surrogate measure for therapeutic efficacy. And why do TTR levels rise with stabilizer therapy? We don't exactly know. So again, from Jeff Kelly's group, possible reasons include decreases in the extent of protein TTR misfolding in blood plasma, decreased TTR degradation in liver and after secretion, improved secretion of TTR from liver. And he concluded the value of using plasma TTR as a biomarker for therapeutic efficacy is uncertain, as it may vary with different stabilizers and different TTR genotypes. No association was found between TTR response to stabilizer therapy in ATTR polyneuropathy. In the ideal kinetic stabilizer would stabilize TTR to misfolding without changing its turnover rate and thereby increasing the TTR concentration. Furthermore, there are many factors that affect TTR stabilization. In TTR stabilization is the underlying mechanism that we really want to know about. And according to Jeff Kelly, there are 5 factors: the affinity of the stabilizer to TTR, the affinity of the stabilizer for albumin, the plasma concentration of the stabilizer, the plasma concentration of TTR, the plasma concentration of albumin. So it's not just one parameter. There are many things that go into this chemistry. And so it's presumptuous to think that we can just measure plasma concentration and we're done. Let me hand it off to my relief pitcher.
Gee, thanks for the opportunity. Let's see. So you've already heard about how TTR is measured. So I'm not going to go into that in too much detail, except to say that the typical clinical measurement is of only one form of TTR, and it's not the form that forms the amyloids, so it's not the disease-causing form. So it's by indirect accumulation of tetramer TTR that we can assume that there's a less of the monomer, which is the amyloid causing form. So this reminded us of the beginning assays of cholesterol metabolism. Many years ago, even before my time, we could measure plasma cholesterol, and that was it. We didn't even know about lipoproteins and cholesterol trafficking. And we thought plasma cholesterol was the end all to predict atherosclerosis. And of course, it's not. So more research had to be done, and you know how much, to develop all the knowledge of lipoproteins that we now have. And that has improved the use of those assays for cholesterol and lipoproteins, with a variable assay for cholesterol, as prognostic indicators for atherosclerosis. So I wanted to kind of mention some different ways that TTR is measured. There's direct measurements, which is we've talked about a couple of times at this meeting, in the common clinical lab assay. And I don't know how many of you are involved in developing clinical lab assays. I'm not, and I don't think any of the people up here are, but we like to develop something that is accurate, precise, inexpensive, and rapid. So that's a tall order. And so turbinipatry is a simple test, and it is a currently used clinical lab test, most common one anyway. Immunoblots on a Western analysis can tell you monomers and oligomers, and let's say monomers are the causative form, but that's in the research lab. Dynamics of tetramer formation, absolutely important to understand, just like the dynamics of HDL and LDL and other lipoprotein interchange, also in the research lab. But there's indirect ways that are coming of age now. And since TTR, for example, amyloids in the heart causes fibrosis in the heart, the levels of fibrotic proteins in plasma goes up. Indirect also can use proteomics, which is now becoming a benchtop tool in the clinical lab, to measure all proteins and all forms of every protein in the plasma. And we can use AI to sort it out for diagnostics. And indirect, of course, the gut microbiome changes with the levels of TTR in the plasma. So I don't have any time to talk too much about this, but I think I made my point with developing the cholesterol assays, and the same is true with BNP. We used to think BNP was the end-all assay for heart failure, and it probably would be if we had sensitive enough assays. So we went with NTP, which is a surrogate of BNP, and we had to prove that it's an accurate surrogate in order to use it for a heart failure indicator. These are all the requirements for biomarkers. And so in summary, we think that the relationship of plasma TTR levels and cardiac phenotype is unclear. The TTR dynamics and circulation are complex and not sorted out. And there's the rest I'm told to stop.
We gotta follow the rules. So now we have